What if I told you that some drugs can make your body relax and slow down, while others can shut down your digestion and increase your heart rate? Welcome to the world of parasympathomimetic and parasympatholytic drugs, powerful medications that either enhance or block the parasympathetic nervous system, or PNS. These drugs are like the gas pedal and brake pedal for your PNS, and understanding how they work is key for anyone interested in medicine, pharmacology, or just how their own body works. Let's break down the science behind these drugs and their real-world medical applications. Before we dive into the drugs themselves, let's take a quick but important detour to understand what the parasympathetic nervous system actually does. The PNS is in charge of the rest and digest mode. It's like that friend who's always down to chill, relax, and enjoy a good meal. The PNS controls a bunch of involuntary functions that keep your body running smoothly without you even realizing it. Think slowing down your heart rate, stimulating digestion and saliva production, constricting your pupils, and even enhancing urination and defecation. Now, the key player in all of this is a neurotransmitter called acetylcholine. Acetylcholine binds to specific acetylcholine receptors called muscarinic and nicotinic receptors, which then trigger those parasympathetic effects. Parasympathomimetic drugs mimic acetylcholine's actions, while parasympatholytic drugs block them. Now let's talk about those drugs that enhance the PNS. The parasympathomimetics, also known as cholinergic agonists. They do this by either directly stimulating those muscarinic and nicotinic receptors or by preventing the breakdown of acetylcholine. Why would we want to do this? Well, there are actually a lot of medical conditions where giving the PNS a little boost can be super helpful. For example, they can be used to treat urinary retention, a condition where people have trouble emptying their bladder completely. Within the parasympathomimetic family, we have two main types: direct-acting and indirect-acting. Direct-acting parasympathomimetics bind directly to those acetylcholine receptors and activate the parasympathetic response. They are categorized based on their receptor selectivity, primarily into muscarinic and nicotinic agonists. Muscarinic agonists act on muscarinic receptors and can be further classified into non-selective and selective types. Non-selective muscarinic agonists include bethanicol, which is used for urinary retention, and postoperative ileus by enhancing bladder contraction and gastrointestinal motility. Carbachol is used in glaucoma treatment as it increases aqueous humor outflow, reducing intraocular pressure. Methacholine is employed in bronchial challenge tests to diagnose asthma due to its ability to induce bronchoconstriction. Selective muscarinic agonists such as pilocarpine are used for angle closure glaucoma by pupil miosis and xerostomia or dry mouth by stimulating exocrine gland secretions. Cevimeline, a selective M3 receptor agonist, is specifically used for Sjogren's syndrome-associated dry mouth, offering fewer systemic side effects like excessive sweating compared to pilocarpine. Nicotinic agonists act on nicotinic receptors and include nicotine, which stimulates autonomic ganglia and the central nervous system, leading to increased alertness but also dependence. Varenicline is a partial nicotinic receptor agonist used for smoking cessation helping to reduce cravings and withdrawal symptoms. Acetylcholine, a depolarizing neuromuscular blocker, is used in rapid sequence intubation to induce muscle paralysis temporarily, making it essential in emergency airway management. Indirect acting parasympathomimetics work by inhibiting an enzyme called acetylcholinesterase, allowing acetylcholine to hang out longer and exert its effects. This inhibition increases acetylcholine levels at both muscarinic and nicotinic receptors, amplifying parasympathetic activity and neuromuscular transmission. Reversible cholinesterase inhibitors temporarily inhibit acetylcholinesterase, increasing acetylcholine levels at synapses. They are categorized based on their solubility, which determines their ability to cross the blood-brain barrier and their site of action. Lipid-soluble cholinesterase inhibitors are non-polar, allowing them to cross the blood-brain barrier and act on both the central nervous system and peripheral nervous system. These drugs are particularly useful for neurological conditions such as Alzheimer's disease and anticholinergic toxicity. For Alzheimer's disease, donepezil is a commonly prescribed drug due to its long half-life, allowing for once-daily dosing, making it convenient for patients. Rivastigmine, available as an oral formulation or transdermal patch, is useful for patients with swallowing difficulties or those requiring steady drug delivery. Galantamine enhances cholinergic transmission by not only inhibiting acetylcholinesterase but also modulating nicotinic receptors, making it another effective option. In cases of anticholinergic toxicity, physostigmine is the only cholinesterase inhibitor that can reverse both central and peripheral anticholinergic effects. It is particularly useful in atropine poisoning and scopolamine overdose. However, it is contraindicated in tricyclic antidepressant poisoning due to the risk of seizures and cardiac arrhythmias. On the other hand, water-soluble cholinesterase inhibitors are polar, meaning they do not cross the blood-brain barrier and act only on peripheral cholinergic receptors, such as those at the neuromuscular junction and autonomic nervous system. These drugs are primarily used for myasthenia gravis and neuromuscular disorders. Neostigmine is widely used for myasthenia gravis treatment, cobra bite, post-operative ileus, and urinary retention. Additionally, it plays a key role in reversing neuromuscular blockade caused by non-depolarizing muscle relaxants like rocuronium or vecuronium. Pyridostigmine, with its longer duration of action compared to neostigmine, is considered the first-line treatment for myasthenia gravis, providing sustained symptom relief. For diagnostic purposes, edrophonium, an ultra-short-acting cholinesterase inhibitor, is used in the tensilon test to diagnose myasthenia gravis. A rapid improvement in muscle strength after administration confirms the diagnosis, distinguishing myasthenia gravis from other neuromuscular disorders. The classification of cholinesterase inhibitors based on solubility is crucial for understanding their therapeutic applications. Lipid-soluble inhibitors are ideal for CNS-related conditions like Alzheimer's and atropine toxicity, whereas water-soluble inhibitors are more effective for neuromuscular conditions like myasthenia gravis and surgical reversal of neuromuscular blockade. In contrast, irreversible cholinesterase inhibitors permanently inhibit acetylcholinesterase, leading to prolonged cholinergic stimulation. These include organophosphates and carbamates, which when consumed can result in organophosphate carbamate poisoning. You can watch our video on organophosphate poisoning for more information. Now, let's switch gears and talk about the other side of the coin, parasympatholytic drugs, also known as anticholinergics. They work by blocking acetylcholine from binding to those muscarinic receptors, effectively reducing the effects of the parasympathetic nervous system. Why would we want to block the PSNS? Well, sometimes having too much of a good thing can be a problem. For example, in conditions like bradycardia, where the heart rate is too slow, or overactive bladder, where people experience a frequent and urgent need to urinate. Blocking the PSNS can help to restore balance. The most common type is muscarinic antagonists, which work by directly blocking the muscarinic receptors M1 to M5. They're like those bouncers at a club who selectively deny entry to certain molecules, in this case, acetylcholine. Muscarinic antagonists are classified based on their solubility and site of action, determining whether they affect the central nervous system or act peripherally on the respiratory, gastrointestinal, urinary, ocular, or cardiovascular systems. CNS-acting muscarinic antagonists, which are lipid-soluble and capable of crossing the blood-brain barrier, are primarily used for conditions such as Parkinson's disease, motion sickness, and organophosphate poisoning. Atropine, a non-selective muscarinic antagonist, is commonly used to treat bradycardia, counteract organophosphate poisoning, and induce pupil dilation during eye examinations. It works by blocking parasympathetic activity, leading to increased heart rate and reduced secretions. Scopolamine, known for its strong CNS depressant effects, is widely used for motion sickness prevention as it blocks muscarinic receptors in the vestibular system, thereby reducing nausea. However, its sedative and amnestic properties also make it useful as a pre-anesthetic medication. Benztropine and trihexyphenidyl, both centrally acting anticholinergics, are frequently prescribed for Parkinson's disease and for managing extrapyramidal symptoms caused by antipsychotic medications. By inhibiting cholinergic overactivity in the brain's nigrostriatal pathway, they help alleviate tremors and rigidity. In contrast, peripheral-acting muscarinic antagonists, which are water-soluble and do not cross the blood-brain barrier, exert their effects on organs such as the lungs, gastrointestinal tract, bladder, eyes, and heart. In respiratory conditions like asthma and chronic obstructive pulmonary disease, muscarinic antagonists block M3 receptors in the airways, leading to bronchodilation and decreased mucus secretion. Ipratropium, a short-acting bronchodilator, is commonly used during acute COPD and asthma exacerbations, whereas tiotropium, a long-acting bronchodilator, is preferred for chronic COPD management. In gastrointestinal disorders, muscarinic antagonists help reduce gut motility and secretions, providing relief from cramping and spasms. Dicyclamine is frequently prescribed for irritable bowel syndrome to relax intestinal muscles and reduce spasms, while hyoscyamine is used in peptic ulcers and other GI disorders to alleviate excessive gut motility. For urinary conditions such as overactive bladder and incontinence, muscarinic antagonists work by inhibiting M3 receptors in the bladder, decreasing urinary urgency and frequency. Oxybutynin, a non-selective muscarinic antagonist, is widely used to manage overactive bladder symptoms, but its systemic side effects, including dry mouth, have led to the development of more selective agents. Flavoxate is another medication that is less powerful than oxybutynin, but has fewer side effects such as dry mouth. Tolterodine, solifenacin, and darifenacin, which specifically target M3 receptors, offer bladder relaxation with fewer unwanted side effects. In ophthalmology, muscarinic antagonists are used to induce pupil dilation or mydriasis by blocking M3 receptors in the iris sphincter muscle. Atropine provides long-lasting mydriasis, making it beneficial for treating UVTs and refractive error testing, while tropicamide, a short-acting alternative, is preferred for routine eye examinations due to its quicker recovery time. In cardiac conditions such as bradycardia and atrioventricular block, muscarinic antagonists block M2 receptors in the heart, thereby reducing parasympathetic activity and increasing heart rate. Atropine is the first-line treatment in these cases, as it enhances conduction through the AV node and prevents excessive vagal stimulation that slows the heart. To reduce gland secretion in pre-anesthetic settings, glycopyrrolate is preferred. Glycopyrrolate binds to M1 to M3 receptors peripherally, decreasing secretion and GI motility, and it does not cause CNS effects, unlike atropine or scopolamine. It is therefore considered superior to atropine in surgical settings and does not cause significant tachycardia or hallucinations, making it safe for elderly patients. Then we have nicotinic antagonists, which primarily affect neuromuscular transmission and are often used as muscle relaxants during surgery. They are non-depolarizing neuromuscular blockers such as rocuronium, vecuronium, pancuronium, which competitively block acetylcholine nicotinic receptors. While parasympathomimetic and parasympatholytic drugs are incredibly useful in medicine, it's crucial to remember that they are powerful substances that can have serious side effects if not used correctly. Overdoses and exposure to certain toxins can disrupt the delicate balance of the autonomic nervous system, leading to life-threatening conditions. One such condition is cholinergic crisis, which occurs when there's too much acetylcholine in the body. This can happen with overdoses of cholinesterase inhibitors or exposure to organophosphates, which are found in pesticides and nerve agents. The excessive acetylcholine stimulation leads to a cascade of symptoms, often remembered by the acronym SLUDGE: salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis, or vomiting. In cholinergic crisis, atropine, a parasympatholytic, is given to block the excessive acetylcholine effects. On the flip side, we have anticholinergic toxicity, which results from blocking too much acetylcholine. This can occur with overdoses of drugs like atropine, scopolamine, or even some antihistamines. The hallmark symptoms follow the classic mnemonic, mad as a hatter. Confusion, hallucinations, delirium. Blind as a bat, pupil dilation, blurry vision, hot as a hair, hyperthermia, and dry as a bone, dry mouth, urinary retention, absent sweat production. Additional signs include tachycardia, flush skin, and ileus, intestinal paralysis. Severe toxicity can lead to seizures, coma, and even death due to cardiovascular instability. Recognizing and treating these conditions quickly is essential. Physostigmine, a cholinesterase inhibitor that crosses the blood-brain barrier, is the antidote of choice, as it increases acetylcholine levels and directly counteracts CNS and peripheral effects. However, it is used cautiously due to the risk of seizures and bradycardia. So, there you have it. A crash course on parasympathomimetic and parasympatholytic drugs. These medications are like the unsung heroes of medicine, quietly working behind the scenes to regulate the autonomic nervous system and treat a wide range of conditions, from controlling heart rate and bladder function to managing respiratory disorders and neurological diseases. These drugs are critical tools in the hands of medical professionals. Understanding how they work, their potential benefits, and the risks associated with their use is essential for anyone involved in healthcare. Remember, these drugs are powerful tools that, when used correctly, can control the autonomic nervous system and restore balance to the body. See you next time. Keep watching MedGroww and take care of yourself.